Hello. So today we're going to talk about three ECG mistakes that break medics' confidence and how to fix them. So let's say you're given this ECG and you're told to read it quickly. So remember the rate, rhythm, regularity, axis, intervals, context system. And that's what I'm going to quickly use to read this ECG. In terms of the rate, there are about 4 big squares between this first and second wave on my left 2. And that brings it to 300/4. My heart rate is about 75, right? And is there a P wave before every QRS wave? Yes. P wave before every QRS wave. Well, looks like a sinus rhythm to me across brothers, right? Then you're checking. What am I checking for next? The regularity. Now there are 4 big squares here, but when I go to the latter part of this ECG, it looks more extended, about 5, if I'm correct. And so 5, but bearing that in mind, the PR interval looks the same across all borders. So I know this V2, V3 sort of looks off, but when you look at it as well, there's a P wave followed by a QRS wave. And, it reproduces the kind of prolongation that we are finding in the later part of the segment. So basically, this is a sinus rhythm with a normal heart rate. However, it looks like the RR interval widens in the later segment. But the PR interval is the same. It's just the RR interval that is different. The QRS and the P morphology are the same across board. So this is looking like a sinus arrhythmia already to me. The QRS is positive in LED1, positive in AVF. This is a normal axis. In terms of the intervals, the PR interval is looking with about 3 to 4, 3 small squares, same across board. The QRS is less than 3, which is normal. The QT that we would need to calculate, and with the heart rate, just to be sure, you use Bazet's formula, but grossly fine here. In terms of the ST segment, because that's also part of my intervals, I check the morphology, the context, the ST segment. And now for that, I do 2-3 AVF. I use the 5-zone method. So 2-3 AVF will form a zone, right? Then V1 to V4 is another zone. 1 AVL would be another zone, and V5, 1 AVL, V5, and V6, right? And then I look across all of that, and I do not find an ST segment elevation. If you're confused about V1, V2, V3, do draw a line from your P wave here to your Q, to the J point where the ST segment starts, and it falls on the same line here. So we don't have a problem. So what is my diagnosis of the ECG? Before I say my diagnosis, I have to know the context, especially this is not an exam. There's a real patient in front of me. Where is this patient? How old are they? Why have they done this ECG? Are they in pain? Do they have cardiac chest pain? And in this case, I think patient is young, maybe in their mid-30s, and they've come in with pain that is not cardiac sounding, is not constricting in nature, not brought on by activity, not improved with rest, worse on movement in the lateral aspect. Sounding musculoskeletal, isn't it? This ECG is sinus arrhythmia. And with sinus arrhythmia, what you have is that you can have prolonged RR intervals that show how the change in respiration, change in breathing is. And this is a benign ECG. I don't have to worry. But what are those mistakes that break the confidence of medics? Reading in isolation. Remember what I said, you can't decode what you don't contextualize. Also, what medics do is they look at a random ECG and they panic before knowing the story. Say they see an ST segment elevation. Of course, it's an emergency, but you always have to know the context. If you see an ST segment elevation, it might be an emergency, it might not be, but context will save you. Even if you see a normal ECG that is very chill, a normal ECG or heart tracing that is very chill, you've got to know the story, because the story can change how you will escalate that to an emergency or not, or whether you do serial ECGs, TROPs. And a way to know the context is also by checking their past records. Now, context converts confusion to confidence. Another thing that medics do is they memorize instead of scanning. ECGs are not exams. Real life ECGs are not exams. They are maps to read. So what medics do is they try to memorize ST patterns, QT ranges, bundle rules, but there has to be a flow. You will always fall to the level of your systems. In an emergency, even with ALS, I find that if you're not calm, collected, if you don't have a system that you know and that you use to scan, then you will not be confident with your ECGs. If you need, there's an ECG where I actually map out the exact zones. If you want that, please let me know, and I'm happy to send that document. Now, use the 5-zone method: rate, reading, regularity, axis intervals, and context, just like you've seen me do, and always follow sequence. Try as much as possible not to follow shortcuts. Every ECG you see means there's a life involved. Sometimes they overcall normal variants. Confidence comes when you can explain when something is normal. Don't say something is normal, where this looks normal, this looks normal. No, don't let complacency also take over. At the same time, don't panic when you see ST elevation or T wave inversion, right? Don't panic. What you need to do is you need to ask, for example, in cases of early repolarization, what you want to check: is this an early repolarization? Is it benign or is it malignant? And how you can check that is, are there reciprocal changes? Is the QRS, when you do serial ECGs, does anything change with the ECG, right? The T wave in early repolarization is often asymmetrical. You always have concave smileys, you know, and that does, to be fair, require a bit of a background knowledge on ECGs. But if you're not getting reciprocal changes, if your patient is young, fit, elderly, if they're not symptomatic, you know, then most likely this is a benign early repolarization. But if they're above 50, for instance, and they're symptomatic, or they're young and symptomatic in terms of a proper cardiac pain, or there's something about their history that makes you want to dig deeper, please, by all means, do dig up. But otherwise, stay calm enough so that you can explain why that ECG is normal for this patient. Now, every art has personality. You're not going to have the same ECG as I would, and as someone else would. So even though we know this is what should be normal in terms of knowledge, check against their past ECGs, do serial ECGs if you're not sure, investigate further if you're not sure. Know that no two ECGs will be the same. And just the same way we will have someone that has a pulse rate of about 50 beats per minute or 54 beats per minute being normal for them. It's the same way that you may have an ST segment looking a bit off, but being normal for that patient. But by all means, investigate, dig deeper if you have good reason to suspect. Just know in your mind that you should not panic. Take things sequentially, scan your ECG, right? And, you know, compare with previous ECGs. You can investigate, you can do serial ECGs if you're not sure, but with time, your confidence builds and you know how to draw the fine line between complacency and being too panicky. So the 30-second ECG checklist is the P wave before every QRS wave, is the reading regular, is the rate roughly normal, are the lead 1 and AVF positive, is the QRS narrow or wide, is it less than 120, in which case it's supraventricular, greater than 120 ventricular, and the ST segments are lamb, compare across leads, does the clinical story fit? If you need this document, it's just a few pages, let me know, I can send that as well. But see you in the next one. Until then, decode ECGs one at a time, safely and you know, promptly. Thank you.